All right, looks like the screen share is working so far. So I'll just give you a little background. As Anna said, I'm Ben Leroy, the Senior Director of Special Population Programs for Santa Rosa Community Health. Paula Diaz, unfortunately, is out on a leave of absence. She's our program manager for a highly qualified community health center. So I'm getting a message that my internet's unstable, so I'm going to turn off my camera. We're a federally qualified community health center located in Santa Rosa, California. So we're located about 50 miles north of San Francisco in the Sonoma wine country. All right. And I won't read everything on the slide here, but it kind of goes into our values, which I presume are pretty similar to the values of your respective organizations as well. But we're a fairly qualified health center. We have about 8 clinic sites, and we see about 40,000 patients each year. We provide primary care, mental health and behavioral health care, substance use disorder treatment with medication-assisted treatment. We have dental services, and then, of course, enabling services like case management and benefit enrollment. And Team Vita is what we call our Ryan White team that serves patients living with HIV and AIDS. We call it Team Vita so patients can talk about our team without having to say HIV or AIDS, and to kind of promote the life and liveliness of our patients. Our team provides outpatient ambulatory health services, medical case management, treatment adherence, non-medical case management, psychosocial support, and we have a clinical pharmacist as well. And of course, the subject of this presentation will be our comprehensive benefit enrollment. And our team has a dedicated quality specialist who helps lead our quality improvement efforts and does an amazing job of providing data feedback to our team. So I wanted to call that out given the subject of this presentation. So the project that we worked on was a comprehensive healthcare coverage project. And the purpose of our project was pretty simple. It was to align with our State Department of Public Health non-medical case management performance measure that Ryan White Part B grantees are asked to work on if they are receiving funds for non-medical case management and if they're receiving funds for clinical quality management. And our ultimate goal was to ensure that all of our patients had the most continuous and comprehensive healthcare insurance or coverage that they qualified for, and that we were accurately entering this data into the state of California's ARIES database, which is the data system that all Part B recipients in the state of California are asked to enter data, at least for a few more months. So our project, our methodology was fairly simple. I mean, this was an easy project to pitch to our staff because it was an amazing cause, and the patient benefits were very, very clear. This wasn't sort of asking people to enter in a code somewhere that had no bearing on patient care. And our methodology was really to look at baseline data. We reviewed our data both in the ARIES state database as well as our own organization EHR. And then we reviewed all of our benefit enrollment workflows. So we understood what our baseline was. And then we did a team-based project with everyone on the team. We have one staff member who's really the lead on benefit enrollment, and that's a huge, huge part of her role. But of course, it takes a whole team to really ensure that all patients are getting the highest level of care possible. And in this case, ensuring that they had the highest level of insurance or coverage possible. We had a team, so it was team-based, and we had regular check-ins with staff to get feedback and to help inform PDSA cycles. Obviously, it's kind of an iterative process. You make little tweaks, see how it goes, and then potentially make additional tweaks as we go along. So we shared the goal with our team members, and our manager did an amazing job of making it real by tying it to a true story of someone, one of our patients, and what it was like for that patient before and after their benefits. In our case, being on Medi-Cal, which is California's version of Medicaid. And our team was really emotionally touched and became really motivated because of that sort of putting a human face on what the issue was. And as I said, we had continuous improvement check-ins. We met with the team every month. We reviewed our insurance status report, and then our insurance specialist would go and try to find folks that needed to be enrolled in insurance, or at least contacted to see if they qualified for something. And here we'll skip to the end, and you can kind of see the change over time. So the graph that we're seeing is the percentage of clients who were receiving the non-medical case management service at Santa Rosa Community Health that were enrolled in the comprehensive healthcare coverage. And you will see a pretty huge jump between February and March 2021. And that is because we made workflow changes at that time. And it's also because part of this project was really quality assurance and not just quality improvement, and that we really needed to confirm the data that we were inputting into the state ARIES database. Because we found that we did have some folks who were on Medi-Cal or other health insurance in our organization's EHR system, but when we went into ARIES, they were not. Or we had patients in ARIES that needed to be deactivated because they had already transferred care away from our organization. So at this point in time, we did both things. We did workflow changes to help ensure that we got more patients enrolled, but we also made sure that our data in ARIES was accurate. And that's really what led to this huge jump between February and March 2021. So we did learn some lessons and kind of what some of our successes were and how they came about. Chief among them was really having a dedicated HIV quality specialist that was just dedicated to our Ryan White team and wasn't being shared throughout the organization was really essential in driving the projects forward. Just because we're a large community health center, some of you may work for larger organizations as well, where the Ryan White services are just one small component of what you do. And if we were using the organization's quality team to do this, they would have had so many competing priorities with 40,000 patients and the typical quality improvement or performance improvement metrics that we're required to meet, either for HRSA or the state or our local managed care and Medicaid plan, that have been really hard to get timely information in the way that we were able to do with a dedicated quality specialist who's dedicated just to our HIV team. We also use an external data warehouse to help us with our reporting. So we're not sort of limited to what's available with canned reports within our EHR system. This is hugely helpful. So we're able to kind of write and code SQL reports and basically slice and dice the data and even help visualize the data using our data analysis tool. And so having that ability to do that and not be limited to canned reports in the HR system was a huge benefit. We also allow our team to attend an annual quality conference, and that really helps reinforce the basic tenets of quality improvement for a lot of our frontline staff. We have a quality meeting every month, but in between meetings, there's not a lot of reinforcement of the quality unless they're coming to separate sort of project meetings. And going to this conference to get them away from their day-to-day duties and kind of reinforce things that they may have already heard before, but need some reinforcement on it is just really, really helpful. And they really appreciate getting that time away to kind of either learn new things or to remember things they may have learned in the past. And we had to give our team members adequate time to work on this project. So we couldn't sort of say, well, you're already doing 50 hours of work in a 40-hour work week. Here's 5 more hours of work we need you to do. So we had to really carve out time for people to be able to do this work. And they really appreciated it. And I think we found that the quality of the quality work went up really well because of that. And of course, we had to continuously check in with the team every month, not just to review the data reports, but also to recognize people for their efforts. So when we had successes, we called those out with individual patients, as well as team members who went above and beyond to help serve those patients. And by recognizing team members in that public way, giving people kudos and plaudits, it really helps people feel good about the work they're doing and make them want to continue to do that work. That doesn't mean that there's no challenges. Of course, we certainly did have challenges. Some of our patients lead complex lives and tend to miss or no-show for many appointments. And that's challenging because then our enrollment specialist isn't able to kind of contact them and talk to them as we emerge from, being able to, when patients are in clinic, it's just very easy for us to say, okay, now we're going to, now that you've seen the provider, we're going to have you see the quality specialist or have you see our benefit enrollment specialist. Also, getting income updates for some patients was really challenging. We do contact patients twice a year to update income, but many folks do not respond. And so we're constantly trying to follow up with people to get income updates, which of course is a big factor in seeing what type of insurance or coverage someone may qualify for. In addition, we found we did have to adjust our workflow for when our patients meet our enrollment specialist. And we had them begin meeting with her prior to seeing the provider. Instead of coming after the provider visit, because we found that some patients would come see the provider, and even though they had an appointment on the books with our appointment specialist, would skip it and just leave. And so instead, we switched it around. We had them meet with the enrollment specialist first, and then she would warmly hand them off to the provider. And we found that worked much, much better. and got a lot more compliance. We're able to actually enroll a number of people in insurance who didn't realize that they qualified. So just a few best practices. I think our manager found that developing a quality resource guide that was easily accessible to the team was really helpful. We had to allow for administrative time to address the team's questions and provide guidance on the project. And again, I just keep emphasizing this, having a dedicated quality specialist for our HIV team was just a huge benefit in driving forward this quality project. And then we do our best to create a culture of quality within our HIV team. I will say it's still not perfect. We still have some ways to go, but we've started that process. And ways that we've tried to do that is by including everyone on in quality meetings and on quality projects. So that goes for our leadership team, to our providers, down to our medical assistants, anyone who touches patients or is part of the team. We try to involve everyone. Some people's roles may vary with each quality project, but everyone's involved and aware and receiving the same updates as everyone else. And we really try to explain to the team the impact of carrying out the project and how it affects patients' lives, because that's truly what our staff cares most about. They're less concerned with quality scores or reports that we give back to HRSA and things like that. What they really care about is that we're improving our patients' lives. So sharing success stories that are results of the projects that we're doing are a huge part of making this real for people and getting their buy-in and investment and participating in the project. And then we share progress about the projects with the team every single month. So they understand what's happening. And if they may not have played a central role that month, they understand what's happening. It makes sure that they have investment for when their role does come up for something that they do need to be more involved with. And then we make sure the assigned staff have the appropriate skills to actually participate in the project. It's not fair to assign a task to someone when they don't know how to do it, have never done it before, don't have the support that they feel they need to do it. So they need the time to do it, but they also need to know the skills. So if we believe someone may not have the skills we're asking them to do, we'll help mentor them and teach them to do it, or we'll find someone who's more appropriate to do that task. And then, of course, sustaining it as we go along is very challenging. As soon as one project's over, it's easy to forget about it. You have to move on to the next project. So we do try to add project updates to the daily workflow of the team so that people are hearing about some of these things more than just once a month. For this particular project, we still have a monthly insurance status check-in to make sure that we're enrolling as many patients in coverage or insurance as we can, and continue to openly recognize team achievements during our staff meetings. So even if it's not a quality meeting, if our benefit enrollment specialist or another team member went above and beyond to assist a patient, we call it out during meetings, and that really goes a long way to establishing a culture of quality. So here, this slide just shows our team. We just kind of wanted to give you an idea of who we work with, and I'm not going to go through every single person, but Judy Brazis, who is our ADAP and access coordinator, is our main benefit enrollment person, and she played a huge key role with this. And Mona Al-Safar, who is our senior quality specialist, also just played a key role with all the data and reporting. And of course, Paula Diaz, who is our program manager, currently on leave, really helped lead the project and make sure that it went well from start to finish. And then everyone else on the team contributed, including our providers who, if they noticed someone wasn't insured, made sure that they got referred in to see our benefit enrollment specialist. And of course, it's just about teamwork, working together and doing what's best for our patients. And really, a lot can happen if we all work together as a team. And I think our team found that on this project. And with that, I'd be happy to take any questions. I will note that, since Paolo led this project, I may not be able to answer every single question, but I understand the project at a high level and can do my best to try to answer any questions you may have.
Great. Thank you so much for that, Ben. And yes, so we're now open to take any questions you may have for Ben before we move on to the next presenter. So if you have a question, feel free to plop it in the chat, or you can just take yourself off mute and ask your question to Ben. Come on, no one has a question?
All right, going easy on me.
I'm sorry?
I said, oh, they're going easy on me. That's great.
I know, he spent months putting together this presentation, so surely someone would love to ask him a question. And I think I see someone someone is connecting. I thought, oh, I think we have a question from Amy in the chat. Nice to see you factored in the many hats staff wear in order to complete a project. They needed the extra help. Good. So she's paying you a compliment there, Ben, or your agency. And
Thank
Lisa,
you.
sure. Lisa has a question. What is your plan to sustain your improvements?
Yeah, that's a great question because, technically this quality project has ended and we're moving on to others. And what we're doing is we're still reviewing our insurance status report every single month. So even though this isn't technically an active quality project, we're still analyzing who is insured and who's not insured every single month. So if we see someone who's had insurance and fallen off, we reach out to try to get them re-enrolled. Or as we have new patients that transfer in their care or new diagnoses. Of course, we always do that work during the intake process anyway, but if they come up on the insurance report as not having been enrolled, we make special efforts to reach out to those patients.
Good.
Can you tell me a little bit more about you mentioned the annual conference to really kind of give the team time to step away and focus in on QI? What did that look like? Like, was that on site? Was that facilitated internally?
Yeah, so
Really
actually
take
it's
them
through
like completely away from clinic for the day?
Yes, yeah, so
Yeah,
they
just
do.
the logistics of that.
Yeah, no, it's a great question. Yeah, so it is an off-site conference. It's just one day, so it's not like a whole week or anything like that. But our managed care Medicaid plan for our county, I mean, they do multiple counties, but they're the only managed care Medicaid plan in our county. They put on a conference. They basically call it the ABCs of quality improvement. So it is fairly basic, but in a really helpful and really does help introduce people to kind of the building blocks of quality improvement and does kind of go into the PDSA cycles. And so we find our team finds it really helpful. Some have gone more than once to get a refresher. Obviously, we do have some staff turnover on our team. So every year it's nice to get the new people to be able to go. And we've just found that it helps. So then when we're talking about some of these quality projects or using sort of quality lingo during the meetings, they have an understanding of what we're talking about and don't feel like we're talking over their heads, which is something we really don't want to do.
Rena, I see you have a question, so I'm going to give you the opportunity to take yourself off mute and ask Ben directly. Rena? Okay, so I'll go ahead and ask the question that Rena placed in the chat. So essentially, Rena is asking if the HIV specialist meets individually to gather income and housing data.
Oh, yes,
Or
sorry, I
housing
do see
status.
that in the chat now. Thank you, Dennis. Yeah, so our benefit specialist does meet individually with patients to get income once a year, right? We have to get proof of income. We are still continuing to kind of ask people to verify income at the 6-month mark as well, just through self-verification, even though it's no longer required, just because we find it a little helpful. And it gives us another engagement opportunity with our patients. Housing status, we actually collect at intake and then also annually through our medical assistants are actually doing that work for us. So at every visit, basically, if they find that someone hasn't been asked housing status, they're asking that. So I think we are at about 96% on compliance with housing status for our most recent Ryan White services report. And that's another thing we do run reports on so that our medical assistants can see who has answered that question during the calendar year and who still needs to provide that information to us.
Thanks for that question, Rena. Anyone else has a question for Ben? Just look at the chat again. Okay, I don't see any other questions. So Ben, again, thank you so much for presenting, and we can now move on to our next presenter. Oscar, are you ready? So Oscar's having some technical issues, so I will go ahead and try and operate the slides for Oscar. Oscar, could you just do a mic check just to make sure that you're okay?
Okay, yeah, I'm testing and I think I am on. Can you hear me?
All right, great. So let me see if I can go ahead and share my screen and let's see. Let me just do this. Screen. Can you guys see my screen?
You do.
Yes.
Okay, and you've seen your slides, right, Oscar?
Yes.
All right, so you just tell me when to move the slides, okay?
Okay, sure, I will. And I appreciate that. Thank you. I don't know why this, I mean, two laptops was asking me the same register, and then the robot story about going to a motorcycle, signal lights, palm trees, and then again and again and again, 13 times. So I mean, it was interesting. But in this, it's great. It's over. I'm joining from my cell phone, and thank you for the help again. Here in Dallas, we work towards an improvement project. I'm going to mention that again, but I mean, up front, it was the first time that we practiced that in Dallas to create a common quality improvement project among 10 recipients. So it was very interesting. And we create 3 posters, 3 different levels, the basic, intermediate, and advanced around this work. So it was interesting because the work actually creates the words, building the poster presentation. So give me the next. This one was the title of the basic, which is the pedestal, the infrastructure, quality improvement, performance measurement, because after the 2018, we had HRSA visit, and we were definitely a lot of findings. Let's put it in those terms. Very, very like on the ground. So next. And to see what is Dallas County in reference to service model is basically what you have is a clinical specific with the perspective of the clinical service for the clinical interest, and the very focus on the clinic scope, having those determinants, social determinants of health away, behavioral health, oral health, legal services, housing away. The model is kind of dissociated and operating in silos. Otherwise, it was difficult to send someone, refer someone else, someone to a place and receive that as the client went, received the service. We don't know. It was very difficult. It's very difficult to track someone to us referred. But we have 6 subrecipients that focus into the clinical provider piece. We have one, by the way, Brian House. This one is an agency to basically take care of kids who are either affected for mothers who are positive, and they decide to stop in the middle of the year and don't accept more Ryan White dollars. So they stopped right there and couldn't finish the project. Behavioral health, we have 2 agencies who provide behavioral health. Legal service, just 1. Oral health is basically just 2. One is inside the other, but one is independent. So 2 providers for dental care, basically impossible to cover the whole population with 12,000 individuals who might require at least a cleaning. And the basic of dental care with 2 service providers was very difficult. Next. This is our team and our consultants, our coaches. From the right to the left, standing, the director, Dr. Wong, is myself. Down the left, Regina, which is a health advisor. Our assistant director, Sonia Hughes. And on the right, Angie Jones, who is the CQII advisor. On the right, in black, Jamie Shank. And on the left, Michael Hager. Those last 2 are our coaches into this rebuilding the CQM program. And basically helping us to support that big project that was a little difficult, just in paper was still very difficult, and put that in place, it was even more difficult. So next. It was 12 months of, we call it return to care, R2C, for sure. And it was 24 months initially, a project that we're going to focus on those clients who are out of care or at risk to fall out of care. So bringing them back, because the gap is very very noticeable, very big, very, I mean, was difficult to find someone who is out of care. You know, the same complexity to find someone who is about to fall out of care. Both are like a risk being out. The agency didn't follow much on that, and it was difficult as well to bring the agency to pitch in and participate into this project that for the first time in Dallas County, we decide to put that in place. So give me the next one. And of course, is return to care in Dallas County. We focus on this and this logic model. Inputs. What the inputs really basically is. I'm sorry, my lines is a little dry. Inputs on prevention funds, Ryan White Part A and B funds, whatever other relevant funding, and about individuals participating, people living with HIV is crucial. Involve clients, involve consumers in the project. It is vital. You cannot move forward with an effective intervention without consumers. They decide, they know, they are the ones who are going to lead the boats. So look at the best coach that you can have, the best coach that attached to your needs and whatever you have on hand. Use, try to find a way how to store your information, store enough information to provide and spread among staff, subrecipients, and the people who are going to be working pretty hard on this project. So we have, sorry about that. Activities, how to disseminate the information, how to communicate, establish and schedule webinars, trainings, look for interventions that are within your scope, look for those presenters that are already doing it in a different place in the country. Be innovative. The utilization of Continuous is a company that provides a tablet, and that tablet going to the client's hands, so be able to be, and this client will be in contact with the provider for telehealth, or in contact with the provider for paperwork, in contact with the provider for medical case management, or any other service that they can receive via tablet. But what happened with that tablet is get lost. Okay, the system, this continuous system, can provide a replacement of the device up to 3 times. And it's innovative, it's new for the client, but there is something interesting that happened around COVID. Everybody gets savvy on the use of electronics. And those who were afraid to use electronics get attached to the electronics as a kid. We noticed some mature individuals who were afraid of the system, afraid of the device. Once they tried and the device worked for them, they were like kids on that device like every day. So it's awesome. Look at the positive out of the situation. You can tell COVID is the result of COVID as well. It's one positive result, at least one. Okay, and focus on output. What we expect. You customize your toolkit. You create your bag, your sack of tools, appropriate tools to manage and monitor your project. It's the tools that you're going to customize. This is very generic. We're going to get into details in the slides ahead. My lyrics is really betraying me. The outcomes, look for input, activities, output, and outcomes. After what? What we were looking for, higher rate of keeping appointments, because the no-show rate for clients who are into Ryan White were around 48%. No-show rate at that point. And with COVID, of course, that rate went higher. Okay. And all of this is happening within the pandemic. So challenges, yes. Increase the retention, increase viral suppression, improve client satisfaction system, improve client satisfaction locally in the system as well. Improve the satisfaction of the subrecipient on the processes from the AA towards the subrecipient. RFPs, contracts, all of those details that really are kind of dry, that can be, okay, that can be innovated, that can be reinforced to improve the satisfaction of the clients we serve. And next, and what happened in our Dallas? Okay, we have these 3 groups. We have 9 recipients: AHF, Prism of North Texas, of RCD. These 3 are providers of medical care. These 3 decide to roll with continued. But what happened with bringing innovation, right? We have the tablet, we have this one. Not because it's innovative, everybody will jump on that. It's another layer of complication, because how are you going to lead the group of people to work towards retention in care, return to care, with a different project? It's coordinating what project can do Cali Clinic, HSNT, and Parkland that coincide with retention, return to care, the same as AHF, the same as ASD, community dental. Bring those 9 individuals, 9 groups to compile and align into return to care project from a different perspective. What happened? 3 of them use continuous tablet to connect with the client wherever they are. 3 of them focus on access to care. Access to care, basically, in Cali Clinic, it's in North Texas. HSNT is North Texas. We call them rural. It's kind of close to Oklahoma. But Parkland is a city. It's the safety net hospital. Those 3 provide medical care. Well, how they actually going to align to be focused on return to care? Different ways to do it. Okay, and what happened? ASD is an agency to provide housing. How ASD will align a project that focus on return to care is bring that idea, brainstorm, meeting with your subrecipient monthly by project, and have that continued communication and technical assistance to subrecipients. So they feel support, they feel that what they're doing is important, they feel that what they're doing reflect into quality of service that they provide to the clients. Next. In the next slide, you'll see different posters. Because over time, what we did, create the poster, each recipient work on their project, and that project will generate a poster with this set. What is the aim statement? The title, the aim statement, the methodology they use to analyze, or maybe pivot, because some of them pivot in the middle of the project, change the scope or change the target. Okay, and they create lessons learned based on the model that they utilize, and the conclusion. What happened? They rate what they're doing. They're looking for example, improve retention of clients less than 35 who identify as an MSM from 62% to 75%. Parkland Rigid, they did. What they use? The average intervention. The average intervention they utilize raised the rate from 62 to 75. You can see in the quadrant lower left, the detailed data, how they are achieved what they were looking for. Well, same with Legacy. Legacy, next. Legacy is a mental health facility. Mental health is a need that not all the patients who actually need the service get the service. It's difficult for this agency because it was in the middle of transition of administration, and the person who came after was completely in a cloud, was next with CQII. And of course, her focus was mental health. Learn what's going on, learn how to manage the agency, not CQM. For this agency was a struggle. Okay, but that's why we as an AA, we as a CQM, we support these agents who are suffering to raise them into a better quality. Good attitude, legacy is one of the agencies to actually get a cap on the evaluation, but learn towards working into the organizational assessment to identify. We're going to talk about the organizational assessment in the few slides, but I want to show you that each slide, give me the next one. This is your health clinic. It's well known as a Cali clinic. Cali clinic is one of the pioneers on the telehealth. On telehealth. But what happened with this agency when everything changed? They were ahead of the curve because they initiated telehealth services way before COVID. And by the time they okay, everybody needs to use telehealth, what happened? They were the pioneers, and they were teaching, they were using the methodology they presented. It was a model of copy for the rest of the subrecipients and some other clinics. They use STD testing to bring those clients who are positive into care. So they were keeping an eye on the STD rates that was very high in that area, and identified that group, testing HIV, and they increased the rate of return to care for those who were out of care or at risk to fall out of care. The resource center, what will happen is with them, they focus on monolingual Hispanic clients. That's a population that really is underserved. So they focus on those individuals, providing tablets to maintain communication, increase the rate of retention, because the tablet offer a huge benefit that you can translate whatever document is coming to you. It can be translated in conversation that you do. The tablet can be used as an interpreter. So it's innovative. Is something that not really everybody will jump on, but those who jump into that is very effective. So give me the next one. We have a few minutes. Legal hospice. Say, is this agency what they do is just reach those clients from the legal perspective, and at the same time offer the questions if they are in care or not. Returning to care, they have to pair with some agencies who are providing HIV care because they provide only legal services. Innovation, creation, models of analysis, root cause analysis, the 5 whys. Next one, this is AHF. AHF, the viral load suppression in this clinic was increased, basically utilizing outreach and look for the clients who are out of care. Next one.
I'm sorry, Oscar, let me just jump in here for a second before we move on to the next. Just to FYI, you have about 17 minutes left. And let me just also, there's a person whose video is showing with a lot of activities in the background. If that person could just turn their camera off. And actually that's Kelly Salinas. That's not connected to your phone, is it, Oscar?
No.
Okay, so Kelly Salinas, if you're hearing me, could you just turn your camera off, please? All right, I'll move on to the next slide.
Yeah. Okay. Yes. No, it's not connected to my phone. It's my wife, by the way. Okay. With the next one, resource center, HST, the next one. Pass to the next slide, please. The next one, this legal hospice. This is AHF. Next one. Even the PRISM, I just want to make a comment on the previous slide with PRISM. This is an agency, one of the largest providers that we have. They pivot at the middle of the project. They find is way too difficult to reach this population. So they changed in another way, using non-medical case management to connect with those clients, and paperwork, access, that increase the utilization of the tablets and increase the retention in care and return to care for those clients who were contacted. So give me the next one, which we're going to talk about the organizational assessment, which is a tool. Basically, it's a tool created to evaluate domains from A to H, all the way down in your CQM program. Where is the strength? Where is the weakness? What we have is a scale of 5 elements, of 5 check boxes on some. Give it the next, but it's basically the evaluation of your CQM program that's offered this domain. Literature in support for CQM from your leadership. Who is supporting you? You don't move if the fiscal individual is not with you. You don't move ahead if the director is not with you. You don't move ahead with that structure that supports you. And the best, you do not move ahead if you don't have a CQM committee managed by consumers. External CQM committees managed by consumers give you the lead and is the best way to move a program in a more realistic way towards the benefit. But you have a list, in this one, you have a list of the domains of the organizational assessment, what they include. CQM committee functions, CQM planning, workforce training, all of those can show how you are working, how good or how halfway are you on the building of your CQM program. So give me the next one. And this is us. This is us on 2020, 21, 22. And we have increased the minimal value that we can have is 3 to have work towards a functional CQM committee. The 22 offered the evaluation from 21, and 23 we are way ahead. In the next step, you will see we are over 3 in all of them except 1. So with the next one, in this, I would like you to show you the quartile in H1. H1 is HIV care continuum, creation and utility of this HIV care continuum towards improvement. So it's the only one with the average show that is under 3. This organizational assessment helps you to identify the work plan for the next year, your goal for the next year in CQM plan, because it's the only area that you have under 3. You focus on that to raise that, the care continuum, how to create it and how to use it. So this tool is extremely functional, and the CQII is the one who created that tool. We use the version of 2020. So next one. But what happened, and this is the best paper on of the whole momentum. Quantitative and qualitative CQM performance measure is innovative, because usually the performance measurement goes in numbers, right? You have viral suppression in numbers. Well, we still have that. Retention in care in numbers, yes. But on what? The the service categories that we have as based on utilization are outpatient, APA, non-medical, medical, outreach, medical transportation, dental care, and referral for healthcare service. So we come up with this innovation, of course, with the collaboration of the subrecipients, because they are the stars. They are the ones who are going to put that in place. And consumers, never forget the consumers. And what happened? We create a small tools, quick response for those service categories that you can definitely adapt a survey, small survey, to determine the performance of the service that the patient received. And in this case, we left, well, for the decision of the recipient, we left outpatient and APA as a quantitative. But if we had a crisis with the data, we decided to get the data from their EMR. Is the data that they have, they're gonna export to us? to measure viral suppression and retention in care for outpatient and APA. But the other ones, we create a tool, individual tool, plug it into a platform, Qualtrics, and went back to the recipients, and they sent that tool. When the patient received the service, they sent the short survey to that patient. That client will send back the feedback, populate the Qualtrics data, and determine performance measurement on the service category received X day. It will be a survey that will they will receive once a month, no more than once a month, and will give the opportunity to the client to decide and determine if the service they received was in covering their needs. Actually, they found what they were looking for. They received the attention that they were looking for. They were completely not covered by XY provider. They will say, they have the chance to say, I received the service, but I complained about this. That immediately create a ticket. We call it a ticket, which is a flag in the system. So the provider is informed that there is one client this week that has complained about specifically transportation. So the subrecipient have the chance to resolve it, help it, move the service into a better category. And if the client leaves the number, they have the chance to call the client and address the issue. So it's a happy client, a good service. So give me the next. Oh, okay. This is the next one was the list of medical, the qualitative and quantitative. Go back.
Is this where you need me to be?
Give me one back.
Performance measures.
Yes, this is the list of quantitative performance measurement and qualitative performance measurement. What we have in quantitative retention in care, we have outpatient ambulatory health service retaining care. We have the possibility to combine if the patient receives medical care or receive LPAP, which is APA, combine the variable of retention in care, and you can see those clients who will utilize LPAP funds, what the retention rate that they have, or outpatient ambulatory, what the retention rate, and viral suppression. Some agencies were like in not agreement with retention in care because they didn't have the way how to move those variables. So they went back, they decide to go back in viral suppression for APA service category. Qualitative, we see medical case management, the most common request was prescriptions. It is an order of frequency. Prescription was the most common request to medical case management. Housing, mental health, transportation, food, and public benefit. In that order, the client went to a case manager looking for this kind of services. For non-medical, the first request, the most popular request was paperwork, care plan review, dental, and housing. Again, housing plays another role in there. Outreach, looking for food, looking for housing, utilities, public benefits, transportation. Oral health, the tool is just 2 questions. If they know enough, they have enough tools to take care of their mouth. Yes, no, they want to be contacted. The main request was, I need a toothbrush and a toothpaste. It's incredible, but it's simple request, big changes. So medical transportation, the most common utilized is bus pass because they have the freedom to go anywhere with that bus pass. So this gives us the need of the client at the moment of the service. Fresh. So next slide. What we learned, the next one was the World AIDS Day flyer. Just a summary of the posters that we saw. December 1st, in World AIDS Day, we present the poster symposium to officials, those who actually helped us to build this CQM, official social director, the judge, our assistant director, and fiscal department. It was very rich in knowledge because each agency came up to present their poster and what they learned in the process of CQM implementation. Because it's interesting that most of them recognize the CQM as a new, which is not new. It's new maybe here. So you might have that detail as well. Best practices: find the right guy and coach you. Find someone who's gonna help you based on what you have available. And important, check your contract. The contract language has to say something in relation to CQM, very specific, so you can go back to those who signed the contract. You have enough ground to ask them for that deliverable. So check that contract. Involvement to the health department official, education, technical assistant, open at any time. You have to adapt whenever they need that TA. Okay. Make the difference to help to create the culture. Make the difference in quality improvement and quality assurance, because it's a mix. It's a melt of concept that everybody think like whatever is quality assurance, it fits into the quality improvement, and it is not. We know that. So it's a journey. So give me the next one, please. How do you create a culture of quality? It's difficult. Just to explain initially what is CQM, turn a little bit like hesitation where to start, because you don't know what people knows about CQM, but educate your own staff, your own department, your own floor, your own building. Start local, educate yourself, recognize what you don't know, and get that, cultivate, and pass it to someone who's going to multiply that factor. Okay, involve everyone from head to toe, that person, everybody is involved in CQM, in your division, in your department, in your building, in your high school. Everybody is involved. Be transparent, be clear. What you don't know, don't know. And express it, I don't know. How to maintain it? Communication, efficiency communication is important. Be transparent, make technical assistance available, and be there. Don't fail. Don't give up. It's not easy. It's not easy at all. It's very, very cumbersome, but it's the work of everybody, not just one or division or one person. Give me the next one. And that actually is the last one. And thank you so much. Quality improvement and performance measurement plus you equals you. So it's important to maintain the vision ahead, and it's not a simple task. It takes a lot of energy, a lot of support, and never
Okay, I think we might have we're having difficulty with your
if you have
audio.
so
Oscar, we have a little difficulty with your audio, and we're
about now?
that's a little better. Go ahead, quickly. Go ahead. You have 30 seconds, Oscar.
Okay. 30 seconds. Okay. Well, thanks so much. If you have any questions, you can email me. My email is oscar.salinas@dallascounty.org, or I'm open if I have time.
Great. Thank you so much, Oscar. Thank you again, Ben. And please, before you guys leave, well, thank you guys for joining, for participating. And just promo, our next webinar will be Thursday, March 30th. So we hope you join us for that one. And let me just quickly launch the poll. Let's see.
On it already.
Oh, you got it? Okay,
Yep.
There you go. Thanks, Shay. Thank you.
Thank you, Dennis.
Thank you so much, Oscar.